Okay, we're going to go through and talk about all the most important chemotherapy drugs and regimens you need to know for solid tumors. So this is not heme malignancies, not sarcomas. These are all your carcinomas, okay? So, it's really helpful to think about these by class. One of the oldest chemotherapy, and you might not have thought about this since medical school, but the oldest chemotherapy class is the alkylators. The original was nitrogen mustard, but the one that's used in solid tumors is cyclophosphamide. Also used in heme malignancies, but cyclophosphamide is sort of your main alkylating drug that you need to know. Um, the next class of drugs would be the topo 2 inhibitors, the most important of which is doxorubicin, which is an anthracycline. So you know about anthracyclines and their side effects. There's another drug called etoposide that's actually a similar mechanism of action. It doesn't have the cardiac toxicities, but it does have late bone marrow problems and myelodysplasia that patients can get. So you should remember that etoposide is a similar class of drug to the anthracyclines. The next would be the topo 1 inhibitors, and that main drug that's used is irinotecan. There are variants on that, but you should understand irinotecan very well, its side effect profile, how it's used. Then there's a whole sort of general group of drugs called antimetabolites. These drugs are mostly limited by cytopenias. They don't cause a lot of nausea, they don't cause a lot of other side effects, they don't cause neuropathy, but they cause cytopenias. The most common is 5-FU, which is given usually over a slow infusion. And then the oral version of that is capecitabine. Can cause cytopenias. Then these drugs can also cause hand-foot syndrome and diarrhea. And then other similar drugs, the other one is gemcitabine. So when you think gemcitabine, most people think pancreatic cancer, biliary malignancies. That's the most common way it's used. And then the last would be pemetrexed. It's only essentially used in non-squamous lung cancer. So non-small cell lung cancer, adenocarcinoma. Pemetrexed is the drug that's used. It's a very common indication, but a very narrow indication. So then the platinum drugs. There are three platinums that are used all the time, and they're very different, really different side effect profiles, different combinations. So the first is carboplatin. When you hear carboplatin and side effects, that causes low blood counts, mild nausea, cytopenia. The next is oxaliplatin, is a platinum used in GI cancers for the most part, causes cytopenias and neuropathy, this cold sensitivity neuropathy. And then the last is cisplatin. Cisplatin, you should think a curable setting. When we're trying to cure cancer, there's a platinum in there. It's almost always a cisplatin. It's used with radiation. Limiting toxicities of cisplatin, nausea, neuropathy, kidney problems, a few other things. But those are the biggies. Next is the class of drugs that affect microtubules. So in solid tumors, it's the taxanes that are used, paclitaxel and docetaxel. The vincas are not really used in solid tumors. They are in heme malignancies. But paclitaxel we usually call it, say, Taxol, and docetaxel, usually physicians will say Taxotere. They're quite different drugs, have different side effects and different indications. You can't just substitute one for the other. And we'll talk about some of those nuances. And then the last kind of throw in is bleomycin. So that drug is used mostly in germ cell tumors. It's in there in some of these regimens. It's important to understand. So now, how do we mix all these together? So the regimens that have been used one way to think about it is cancer's above the diaphragm. So carcinoma is above the diaphragm and below the diaphragm. So we do above the diaphragm first. That's head and neck cancer, lung cancer, breast cancer, esophageal cancer, similar regimens. For like 30 years, carbotaxol was the most common regimen. Of all the people getting chemotherapy, more than half were getting carbotaxol. So that is, the carbotaxol, carbolimta, let's just clip through these and we'll get to the top. So these are the regimens that you have to understand. So carbotaxol, so this is used in lung as well as esophageal cancer, head and neck cancer, breast cancer, breast cancer. And it's complicated because it can be mixed up in different ways. The oldest way to do it is just give big doses of both at once, give carboplatin and give docetaxel every 3 weeks. So those two drugs together. So again, Taxol is paclitaxel, not Taxotere. Don't get them confused. So you can give both drugs once every 3 weeks. The other way you can do it, and usually with radiation, is give a little dose once a week of both drugs. So a little bit of carbo, a little bit of Taxol every week during radiation. And then the way that it's used in triple negative breast cancer, which actually is a great way to use this regimen, is you give carboplatin on day 1, and then you give Taxol, the little dose, once a week. Limiting factor for dose limiting toxicity for carboplatin, cytopenias. For low dose weekly Taxol, neuropathy. So there's almost no overlap in the toxicities, so it ends up being a very well tolerated regimen. So that's carbo and Taxol. Next, carbo and Alimta, which is pemetrexed, only ever used in non-squamous lung cancer. Lung adenocarcinoma, getting chemotherapy, they're going to get carbo-Alimta, carbopemetrexed, given once every 3 weeks. Okay, carbotoposide. When you see carbotoposide, you should think small cell lung cancer. So this very common regimen, and then realize that carboplatin can be substituted with cisplatin. In what setting do you use cisplatin? Curative setting. So in earlier stage, limited stage small cell lung cancer. So cisplatin plus etoposide. It's a little complicated because the carbo or cisplatin is given on the first day, and then you get 3 days of etoposide. So it's 1 day of carbo or cisplatin, then 3 days of etoposide, and do that once every 3 weeks. Okay, next, Taxotere. If patients are getting one chemotherapy drug for a solid tumor, it's probably Taxotere. It's just a great palliative second-line drug used all the time in lung cancer, breast cancer, head and neck cancer, prostate cancer. It's Taxotere. And it's just given once every 3 weeks. You can give it in low dose weekly, but in general, it's almost always once every 3 weeks. Taxotere, like Taxol, can cause neuropathy, but with Taxotere, you get cytopenias and you also get diarrhea. So very different from Taxol. Okay, AC. Used to be that every woman getting chemotherapy for breast cancer got AC, not as much anymore, but still very common. So that's adriamycin and Cytoxan. It's given once every 3 weeks or every 2 weeks, what's called dose dense. So you see dose dense AC, that means getting those two drugs at the same dose once every 2 weeks. If you're going to give chemo every 2 weeks, you got to give Neulasta in between. So that's or a long acting GCSF to get the white count up for the next cycle. So that's AC or dose dense AC. Now, so that's used for high-risk breast cancer, but if you're trying to throw everything at somebody, you do AC, and then you follow it up with a taxane. So usually when AC is given, you're also following up with Taxol, and usually it's weekly. It's that low-dose weekly Taxol regimen. You can do it once every 3 weeks. You can also substitute that out for Taxotere every 3 weeks, but in general, in practice, it's you get 4 doses of AC, followed, so that's 12 weeks every 3 weeks, and then 12 weeks of weekly Taxol. So for high-risk breast cancer, that's the regimen. Okay, for lower-risk breast cancer but still need chemotherapy, so this is a 60-year-old woman who's ER positive but high risk based on molecular features. They're going to get TC, so that's Taxotere and cyclophosphamide. So instead of the A, you just substitute it with the T. So that's easier, no anthracyclines, you don't have the cardiac issues, you don't have the risk of MDS. So that's TC is for the lower-risk breast cancer but still needs chemotherapy. And it's confusing because the C is not carboplatin. It's like AC, but you took out the A, right? It's confusing because TCHP is the HER2 breast cancer regimen. If you have HER2 positive breast cancer, neoadjuvant setting, this would be what you're getting, although these days now the carboplatin is often dropped. So it would just be Taxotere plus Herceptin plus Perjeta. So it would be Taxotere plus carboplatin or Herceptin Perjeta, depending on the setting, depending on the person. But remember that in that HER2 positive, the C is for carbo, and then the Taxotere. And then the HP would be the targeted therapy. Always given once every 3 weeks. Okay, so that's everything you need to know about above the diaphragm. Let's do below the diaphragm. So this is GI. I'm not covering GYN, but in general, all the GI malignancies. So these regimens, these will look familiar to you if you've been around. So FOLFOX is the most common regimen in like upper and lower. I'll put it all together. FOLFOX, extremely common, can be used in almost any GI cancer. Looks complicated, but really it's just 2 drugs. It's infusion of 5-FU, so 48 hours of 5-FU, plus oxaliplatin. The FOL comes from the folinic acid or leucovorin, which is given if you give a bolus 5-FU, then you give leucovorin afterwards to reduce the toxicities. That's often dropped completely in the metastatic setting. So when you see FOLFOX, that means infusion of 5-FU plus oxaliplatin plus or minus leucovorin. Now, what if you took that 5-FU and instead of giving it infusion, you gave the oral form? Well, that's called Zelox. It's also called Capox sometimes because capecitabine is the generic regimen. There's a few different ways to do that. Usually oxaliplatin is given once every 3 weeks, and then you give the oral Zolota or capecitabine for 2 weeks. The dosing is complicated, but that's just, again, 2 drugs. And then FOLFIRI would be, if you gave the 5-FU, But instead of oxaliplatin, you substitute that with irinotecan, which I mentioned, the topo-1 inhibitor. Very common, so that's like the second line regimen for colon cancer. So you'll see people getting FOLFIRI all the time. You can combine those, obviously combine any of these with targeted therapies, but those are the cytotoxic chemo regimens that are used developed in colorectal cancer and then used in other GI cancers as well. What if you combined all those together? That's called FOLFIRINOX. It's the 5-FU, it's the oxaliplatin, it's the irinotecan given every 2 weeks. The regimen that's not on here is a gastric cancer regimen, which would be also 3 drugs. If you had Folfox but added Taxotere, that's called FLOT. So it's the Folfox, 5-FU oxaliplatin, throw in some Taxotere just to make it more effective. That's used perioperatively for gastric cancer. The difference there is the 5-FU is 1 day instead of 2 days. Okay, so those are like the colorectal cancer regimens, the gastric cancer regimens. Then the biliary regimens are a little bit different. So FOLFIRINOX is used in pancreatic cancer, and then the other regimen for pancreatic cancer would be Gem-Abraxane. So Abraxane is a brand name liposomal paclitaxel, so it's the Taxol, but it's in these liposomes, so that reduces the neuropathy. It does increase the cytopenias, and there's some swelling and other things associated with it. But in general, this regimen is really easy to take. It's given in little dose once a week. So it's weekly for 3 weeks and usually a week off. So you get Gem-Abraxane, Gem-Abraxane, Gem-Abraxane. You notice again that the paclitaxel is being used in little dose once a week and not in a big dose. So that's a very common regimen in pancreatic cancer. You can also, instead of the Abraxane, you can use cisplatin. That's used in gallbladder cancer, cholangiocarcinoma. But also was used in sort of like another thing to try in. So bladder cancer is the first line. Everybody with bladder cancer is getting chemotherapy, is getting Gem-Cis. Can also be used in lymphoma, and then it can be used in lung cancer and other things, especially for squamous lung cancer. Very common regimen in squamous lung cancer is Gem-Cis. The dosing can be a little bit different. It can be 2 weeks on, 1 week off, or 3 weeks in a row. But gemcitabine is always given in this once a week dose, either 2 weeks in a row or 3 weeks in a row. And then the cisplatin can be given at the beginning or split. And then the other variation is with carboplatin. So that is a regimen used in breast cancer as gemcitabine plus carboplatin. And then the last, just for your germ cells, would be BEP. So complicated testicular regimen. The cisplatin and the etoposide, remember this from small cell. So small cell is a very highly proliferative tumor, same as germ cell tumors, very fast growing. So cisplatin etoposide used in small cell. This is cisplatin etoposide used in germ cell tumors. But the cisplatin is given a little bit every day for 5 days, along with the etoposide a little bit every day for 5 days. And the bleomycin is given once a week in the middle. So you get the bleomycin every week for like continuously throughout the regimen. Okay, that's almost all the regimens for solid tumors.